Welcome back to the deep dive. Today we've got a really interesting task ahead of us. We're taking what look like incredibly thorough, almost lecture-ready notes on post-traumatic stress disorder and basically turning them into a usable, really insightful clinical walkthrough for you. These sources, they're pretty exceptional. They don't just define PTSD. They seem to lay out the biological wiring diagrams, the psychological models, the whole treatment toolkit.
Yeah, you can really see these notes were designed for someone wanting to master this topic. They cover the clinical picture, the different psychological theories, the practical stuff interventions, all side by side. Our mission really is to help you unpack all of that,
Exactly.
to pull out every key detail and structure it so you get a really deep conversation, making sure you're, instantly up to speed, getting straight to the core ideas. We're going deep into how these notes are structured.
Right. This isn't just a quick summary. It's about synthesizing everything in these notes so you really understand the why behind PTSD and what actually works for treatment. We're aiming for real fluency here. Okay, let's unpack this. Let's start at the beginning. The foundational definition and those 4 essential symptom clusters, the pillars of the syndrome.
Okay, so first things first. PTSD, formally speaking, it's a multi-symptom response. It's triggered by an extremely traumatic event, something experienced directly or maybe witnessed.
Right.
And the key thing that separates it from, say, normal stress is how persistent the symptoms are and how they cluster together. You need symptoms across 4 distinct areas these clusters will talk about for it to be the full syndrome.
And understanding the quality of those symptoms within each cluster is crucial, isn't it? Let's take the first one. Re-experiencing the event. This isn't just having bad memories pop up, is it?
No, not at all. It's much more intense. Core re-experiencing includes intrusive memories, and these are often fragmented, not like a full story. It might be just a smell, a sound, a sudden image.
Sensory fragments.
Exactly, sensory fragments. Then you have recurrent nightmares, which are obviously distressing. And then the really intense one, the flashback. That's where the person feels, physically and emotionally, like they're right back in the event, reliving it now.
Terrifying.
Absolutely. And the notes highlight how intense the distress can be just from reminders, internal thoughts, or external cues.
Which logically leads right into pillar number 2, avoidance of reminders. If any reminder can trigger that level of distress, well, you'd do anything to avoid them.
Precisely. And this avoidance becomes really comprehensive. It's not just avoiding physical places like the scene of an accident. It's avoiding people linked to the trauma, avoiding certain topics in conversation, avoiding specific activities, even avoiding internal things like thoughts or feelings about the event itself.
So it's like their whole world starts to shrink.
That's a perfect way to put it. It's a functional contraction of their life. They might stop driving, as you said, or quit a job, maybe end relationships, all in this desperate attempt to manage the re-experiencing symptoms. Then the third pillar. This one can be particularly tough because it really strikes at a person's sense of self. Negative alterations in cognition and mood.
And this seems really broad. The notes mention everything from memory problems like amnesia for key parts of the event.
Right, not being able to recall crucial moments.
To these profound shifts in how they see themselves in the world. Things like distorted blaming themselves unfairly, or maybe others. That leads to things like survivor guilt or deep shame, right?
Exactly. And then there are those pervasive negative core beliefs that the notes emphasize. Really catastrophic thinking like, I'm permanently damaged, or the world is just inherently dangerous, no one can be trusted.
Wow.
And these beliefs really lock in the mood symptoms. Things like anhedonia, the inability to feel positive emotions, chronic anger, persistent fear, guilt, shame, and this deep sense of alienation, feeling fundamentally different or cut off from everyone else.
That sense of being cut off, it's such a stark contrast to the 4th pillar, which seems to be about being too connected in a hyper-alert way. Arousal and reactivity changes. This is the nervous system stuck on high alert.
Exactly. That's the clinical picture. The nervous system in overdrive. We see chronic irritability, which can sometimes spill over into aggression. We see self-destructive or reckless behavior, maybe substance use, risky driving. Severe hypervigilance is a big one.
Constantly scanning the
Like
environment.
early standing, And an exaggerated startle response. They might jump out of their skin at a noise most people wouldn't even register. Add to that poor concentration and, very commonly reported, severe sleep disturbance. Difficulty falling asleep, staying asleep.
So they never really rest.
Right. The brain's alarm system never fully shuts down, and it's exhausting.
The examples in the notes really bring this home. When you hear someone say, I won't take that red anymore, that's avoidance, plain and simple. Or describing needing to sit with their back to the wall in a restaurant. That's pure hypervigilance right there. It's these four pillars together that create that distinct clinical pattern we recognize as PTSD.
Okay, so once we start seeing those patterns, the next step, according to these notes, is the diagnostic framework. It's presented very clearly, like a clinical checklist. And it emphasizes, just experiencing trauma isn't enough for the diagnosis. It's about the persistence and the specific combination of symptoms meeting certain thresholds.
Right, let's get specific about those thresholds. The notes say, for a full PTSD diagnosis, you need minimum counts across all four clusters. So at least one re-experiencing symptom.
Correct.
At least one avoidance symptom.
Yeah.
At least two arousal reactivity symptoms. And at least two negative cognition mood symptoms. All four boxes have to be ticked, essentially.
That symptom count is crucial, yes. But the real linchpin, the absolute rule, according to these notes, is the time element. Those symptoms, meeting those counts, have to persist for at least 1 month, 30 days or more.
Okay, at least 1 month. Why is that 30-day mark so important? The notes call it a clinical pearl. How does it help differentiate things?
It's critical because it helps us distinguish PTSD from what might be considered a more typical acute stress response.
Yeah.
If someone goes through a horrific event and has all those symptoms re-experiencing, avoidance, mood changes, hyperarousal, but those symptoms start to fade and resolve in less than 1 month.
They get better relatively quickly.
Right. Then we'd classify that as an acute response. The notes here call it post-trauma syndrome. It's an intense reaction, absolutely, but it's time-limited. That 1-month boundary is kind of where the potential pathology shifts from a severe but maybe adaptive stress response to a persistent mental health condition, the PTSD itself.
So beyond 30 days, it suggests the system hasn't reset properly. But there's another layer of complexity mentioned, the delayed expression specifier. What's that about?
Yeah, that's fascinating. It acknowledges that sometimes someone might go through a trauma, and for the first, say, 5 months, they don't quite meet all the symptom criteria. But then maybe 6 months or even later, possibly triggered by another stressor or just a change in their life, the full syndrome emerges.
So it can lie dormant in a way.
Exactly. It emphasizes that the impact of trauma isn't always immediate. It can be like a sleeping giant that wakes up down the road.
Okay, let's shift gears a bit and look at children. The notes make a really important point here. Diagnosing PTSD in kids is tricky because they often show distress differently than adults. They might not verbalize it the same way. The key concept seems to be regression.
Yes, this is a critical warning for anyone working with kids. If you're expecting a child to sit down and describe a flashback in detail, you might miss the diagnosis entirely. You have to look for concrete, observable changes in their behavior, often linked to their developmental stage. Regression losing skills they previously mastered is a major sign.
And the sources give some really clear, specific examples of these developmental red flags. One of the most classic is bedwetting, right? After a child has been reliably toilet trained.
Exactly. That's a very common physiological sign that the child's nervous system is overwhelmed. It's not defiance, it's dysregulation.
What else should we look for?
Well, sometimes severe coping mechanisms manifest as loss of speech. The child might become functionally mute, maybe only in certain situations, unable to talk or seeming to forget how.
Wow.
But perhaps the most telling symptom, directly linked to that re-experiencing pillar we talked about, is the reenactment of the trauma in play.
Okay, tell us more about that. How is trauma play different from just regular imaginative play?
That's a great question. In trauma play, the child often repeats aspects of the traumatic event rigidly, compulsively, over and over again. It tends to lack the usual fun, flexibility, and emotional range of typical play. It feels stuck.
Like they're trying to process it but can't.
Precisely. It's like they're stuck in that memory loop, trying and failing to gain mastery over the overwhelming emotions through repetition. And then other big behavioral shifts, like sudden, extreme clinginess to a caregiver refusing to be separated, that's another major flag. It reflects this desperate need for safety and security after their sense of it was shattered.
So if you see that combination, bedwetting, maybe mutism, that kind of rigid, repetitive trauma play, your radar should immediately be up for potential underlying trauma.
Absolutely. Those are key indicators in pediatric populations.
All right, this next section of the notes seems crucial for understanding why people react so differently. You can have a group of people experience the same terrible event, but only some develop chronic PTSD. The notes lay out 4 different etiological models to help explain this variability.
Yeah. These models are essential. They move us beyond just exposure, PTSD, to understand the contributing factors. Let's start with Model A psychosocial theory. The notes frame this using a helpful three buckets analogy.
Okay, 3 buckets. What are they?
Bucket one is about the traumatic experience itself. Things like its severity, how long it lasted, how close the person was to death or perceived death. Obviously, more intense, inescapable events carry higher risk.
Makes sense. Bucket 2.
Bucket two is the individual. This includes their pre-existing coping skills, their psychological flexibility, maybe past trauma history, and critically, their developmental stage at the time of the trauma. A child's brain is still developing, so it processes trauma differently than an adult brain.
Right. And the third bucket sounds like it's about the aftermath.
Exactly. Bucket three is the recovery environment. This is huge. It involves things like the availability of immediate social support, family, friends, community, and also the broader cultural context. Does the culture validate the person's experience, or does it stigmatize them for showing distress?
So a negative or unsupportive environment can seriously hinder recovery, even if the person has strong individual coping skills.
Absolutely. Recovery rarely happens in a vacuum. A safe, supportive external environment is vital.
Okay, that's the psychosocial view. What about Model B learning theory? This one seems focused on how fear gets learned and maintained.
Yes, learning theory centers on conditioning. Basically, neutral things present during the trauma, maybe a specific sound, a particular smell, the weather that day get associated with the intense fear and danger of the event. They become conditioned triggers.
So later on, encountering that trigger can instantly bring back the fear.
Precisely. But the really key concept here, the mechanism that keeps the PTSD going according to this model, is negative reinforcement. The notes highlight this as critical.
Okay, negative reinforcement. Explain that. How does it maintain the illness?
It's incredibly powerful because it feels like relief. When someone with PTSD successfully avoids one of their conditioned triggers, let's say they take a long detour to avoid the intersection where an accident happened, what happens immediately?
Their anxiety probably drops. They feel better in that moment.
Exactly. That removal of the unpleasant feeling, the anxiety, acts as a reward. It negatively reinforces the avoidance behavior. The brain learns, hey, avoiding that place made the bad feeling go away. Let's do that again.
So the avoidance works in the short term to reduce distress.
Right.
But long term, it prevents them from ever learning that the trigger might actually be safe now. It keeps the fear alive.
Precisely. It prevents extinction of the fear response. That avoidance becomes the primary target in many therapies because it's the engine maintaining the disorder. It feels like self-care, but it's actually maintaining the problem.
Got it. Okay, let's move to the biology. Model C biological theory. The notes say trauma essentially recalibrates the stress circuits in the brain. Which parts are most affected?
The notes point to dysregulation across three key brain areas. First, the amygdala. Think of it as the brain's alarm center or smoke detector. After trauma, the amygdala can become hyperresponsive. It starts signaling danger too easily, too intensely, even in response to minor or ambiguous cues. This directly explains symptoms like hypervigilance and that exaggerated startle response. It's overactive.
Okay, amygdala is the alarm. What else?
Then there's the hippocampus. This structure is crucial for memory formation, particularly putting memories into context, tagging them with time and place information.
Like saying, this happened then, in that place, and it's over now.
Exactly. In chronic PTSD, the hippocampus sometimes shows reduced volume or impaired function. This means the traumatic memory doesn't get properly encoded as a past event. It remains fragmented, raw, and feels like it could happen again right now. This helps explain the intrusive nature of the memories and the flashbacks.
So the memory isn't filed away correctly.
Right. And finally, the HPA axis, the hypothalamic pituitary adrenal axis. This is the body's central stress response system, regulating hormones like cortisol.
And how does that get disrupted?
In chronic PTSD, the HPA axis often shows signs of dysregulation. It might involve persistently low levels of cortisol in some cases, or just an inability to regulate the stress response effectively. This can lead to increased sensitivity to stress, fatigue, emotional numbness. Difficulty concentrating. The system is basically exhausted and can't mount a healthy response to new challenges. It's always on alert, but kind of running on empty.
That paints a picture of real systemic wear and tear. Okay, the final model, Model D cognitive theory, brings us back to how people think about the trauma. The notes call this the shattered assumptions model.
Yes. This theory proposes that trauma violently disrupts our fundamental, often unconscious beliefs about the world and ourselves. Core assumptions like, the world is generally safe, people are basically good, I am capable, my life has meaning, these can be completely shattered by a traumatic experience.
leaving the person feeling lost and unsafe.
Exactly. It creates this profound sense of disorientation. If your core belief was, I am safe, and trauma proves that wrong, the new operating belief might become, I am always in danger or I am permanently damaged. And that negative belief system then justifies the hypervigilance, the avoidance, creating a kind of self-perpetuating loop.
So a big part of therapy, from this perspective, is helping a person rebuild or revise those assumptions.
Precisely. Cognitive interventions focus heavily on this meaning-making process, helping the individual construct a new understanding, a new narrative that incorporates the reality of the trauma but allows them to move forward without being constantly defined by those shattered assumptions.
Okay, so we have these models explaining the why and how. Let's translate this into practical clinical application using the framework from the notes. They contrast different clinical pictures or diagnoses that often come up. We need to be able to distinguish the threat response from, say, a loss response.
Right. The notes revisit post-trauma syndrome first, really cementing its definition as the acute phase. It's related to that extreme stressor. You see evidence like flashbacks, dissociation, maybe amnesia. But crucially, the symptoms resolve in less than 1 month. Documenting this acute phase clearly is important.
Got it. Acute response, less than a month. Then there's complicated grieving. This seems distinct from the core PTSD fear symptoms. It's focused on loss.
Exactly. While trauma often involves threat, it almost always involves loss too. This could be the loss of a person, a physical ability, a job, but also intangible losses, like the loss of one's former self or the loss of that fundamental sense of safety we just discussed.
And how does complicated grieving look different? What's the evidence?
The notes list things like persistent irritability, maybe explosive anger, self-destructive behaviors like substance misuse potentially used to numb the grief, and a real clinical hallmark, survivor guilt.
That comes up again. The notes had that vignette, right? The crash survivor saying, it should have been me.
Yeah.
That intense feeling of having survived when others didn't.
Yes, that moral injury component is often central to complicated grieving. It requires specific therapeutic attention, often separate from addressing the direct fear conditioning of PTSD.
So it's possible, even common, to have both PTSD and complicated grieving happening at the same time.
Absolutely. When you see that combination, the threat response and the loss response intertwine, the treatment plan really needs to address both dimensions. You can't just focus on the fear and ignore the profound grief or guilt.
Okay, that makes sense. So once we have a diagnosis and a comprehensive treatment plan, how do we know if it's working? The notes provide an outcomes evaluation checklist. What are the key signs of progress we should be looking for?
We're essentially looking for tangible evidence that the person is regaining control, functionality, and emotional regulation. The notes list 3 primary outcomes. First, the client can discuss the traumatic event without becoming overwhelmed or panicking. That shows they're processing and integrating it.
Okay, what else?
Second, they demonstrate new adaptive coping strategies. Instead of relying solely on avoidance, they're actively using skills learned in therapy to manage triggers and distress. They're challenging the avoidance.
Right, moving towards the fear instead of away from it.
Exactly. And third, we look for improved relationships and social functioning. Is their world expanding again? Are they re-engaging with work, hobbies, people? That real-world integration is a crucial sign of recovery.
All right, now we get to the really practical part, the interventions.
Yeah.
What do we actually do? The notes start with some fundamental strategies, things you'd use right at the bedside, beginning with standardized trauma screening.
Yeah, the recommendation is to normalize this. Ask brief, sensitive screening questions about trauma history as part of routine care for all patients, just recognizing how common trauma is.
Makes sense.
And then one of the most immediate and vital skills is providing therapeutic presence and grounding, especially if someone is actively dissociating or having a flashback.
Right. The notes stressed how important it is to stay with the patient in that moment. You become their anchor to reality. What's the kind of language we should use? What does grounding actually sound like?
The core script provided is about orienting them back to the present moment, engaging their prefrontal cortex instead of just the fear center. It's things like, you're safe right now. I'm here with you. Very calm, very steady.
Okay.
Then engage their senses. Tell me 3 things you can see in the room right now, or what you feel under your feet. What's one thing you can smell? This pulls their attention out of the internal flashback and into the immediate tangible environment, often paired with encouraging slow-paced breathing.
Got it. Simple, direct, sensory-focused. And all of this needs to happen within the broader framework of trauma-informed care. DIC. the notes lay out those 4 Rs. Can we quickly recap those, especially the last one, resist re-traumatization?
Sure. The 4 Rs are the foundation. First, realize how prevalent trauma is and its potential impact. Second, recognize the signs and symptoms in the people we serve. Third, respond by integrating this knowledge into all our practices and policies.
Okay.
And fourth, perhaps the most crucial and direct interaction, is actively working to resist re-traumatization. This means being incredibly mindful of anything that could inadvertently replicate aspects of the original trauma, particularly dynamics of powerlessness or lack of control.
So beyond asking about, say, having a partner present, which gives choice, what else does resisting re-traumatization look like in practice?
It's about paying attention to the physical environment. Is it calm? Is the lighting harsh? Does the person know where the exits are? It's about avoiding sudden movements or unexpected touch. Critically, it's about maximizing the person's sense of control and autonomy. Explaining procedures clearly, obtaining explicit consent, ensuring they have choices whenever possible. Even things like tone of voice, ensuring privacy, not dismissing their concerns. Any process that feels coercive, rushed, or invalidating risks being re-traumatizing because it echoes that loss of control inherent in the original trauma.
That's a really important operational mindset. Okay, shifting to more formalized treatments, let's talk pharmacologic approaches. What are the go-to medications according to these notes?
The notes clearly point to SSRI's selective serotonin reuptake inhibitors as the first-line pharmacological treatment for PTSD, specifically mentioning sertraline, that's Zoloft, paroxetine, Paxil, and fluoxetine, Prozac.
And what are they primarily targeting?
They're aimed mainly at reducing the severity of intrusive symptoms like flashbacks and nightmares, helping to stabilize mood, and managing the associated anxiety and hyperarousal symptoms, trying to turn down the volume on that overactive alarm system.
The notes also mention an SNRI, venlafaxine, Effexor, and something called topiramate, Topamax, used off-label.
Yes, venlafaxine is another option, working on both serotonin and norepinephrine. Topiramate is sometimes used as an adjunct, meaning alongside an SSRI, potentially to help with specific symptoms like irritability, nightmares, or impulsivity if the first-line agent isn't providing complete relief. But the core message is that medication is primarily for symptom management.
To calm things down enough for the real work to happen.
Exactly. To make it possible for the patient to fully engage in what's considered the backbone of recovery, psychotherapy.
Right. And the notes list 5 main types here. Let's quickly go through them. First, CBT, cognitive behavioral therapy.
CBT focuses on that interplay between thoughts, feelings, and behaviors. In PTSD, it's used to identify and challenge those maladaptive core beliefs, the shattered assumptions we talked about, helping the person develop more balanced and realistic ways of thinking about the trauma, themselves, and the world.
Okay. THEMA-SIT, stress inoculation therapy. Sounds like preparing for battle.
Kind of, yeah. SIT takes a skills-first approach. It explicitly teaches coping skills before confronting the trauma directly. Things like breathing retraining, muscle relaxation, positive self-talk, cognitive restructuring. The idea is to build up the person's toolkit to inoculate them against overwhelming distress so they feel better equipped when they do start to approach trauma-related memories or situations.
Makes sense. Build the armor first. What about DBT, dialectical behavior therapy? When is that particularly useful?
DBT is often brought in when the PTSD is complicated by significant emotional dysregulation, maybe self-harm behaviors, or intense interpersonal difficulties. DBT's strength is teaching 4 core skill modules: mindfulness, distress tolerance, emotion regulation, and interpersonal effectiveness. It gives people concrete tools to manage overwhelming emotions and impulses that might otherwise derail trauma processing.
Okay. Now, for the 2 therapies that seem most directly focused on processing the trauma memories themselves, prolonged exposure, PE, and EMDR, eye movement desensitization and reprocessing, how do these actually work to, like, reset the system, connecting back to those learning and biological models?
Great question. Both PE and EMDR are essentially aiming to extinguish that conditioned fear response we discussed in the learning theory model. Prolonged exposure, PE, does this through direct systematic confrontation.
Oh, so.
It involves 2 main components. First, imaginal exposure, where the patient repeatedly recounts the traumatic memory in detail in the present tense within the therapy session. Second, in vivo exposure, where the patient gradually confronts feared but objectively safe situations, places, or activities they've been avoiding in real life.
So by repeatedly facing the memory and the triggers without the feared catastrophe happening.
The brain learns through habituation. The fear response gradually decreases. The amygdala essentially learns, okay, this memory, this situation, it's uncomfortable, but it's not actually dangerous now. PE directly challenges and breaks the negative reinforcement cycle of avoidance.
Okay, that's PE. What about EMDR? It sounds a bit different with the eye movements.
EMDR is a bit more complex, and the exact mechanism is still debated, but the core idea is that it facilitates the brain's natural information processing system. It involves having the patient briefly hold aspects of the distressing memory in mind while simultaneously engaging in bilateral stimulation, typically guided eye movements, but it can also be alternating sounds or
And
taps.
what's the theory behind why that helps?
One leading theory, mentioned in the notes implicitly, is that the bilateral stimulation taxes the brain's working memory. The brain is trying to process the emotional load of the trauma memory and track the sensory input at the same time. This dual attention seems to disrupt the way the memory is stored.
So it kind of loosens the memory's grip.
Exactly. It seems to decrease the vividness and emotional charge associated with the memory. It doesn't erase the memory, but it helps integrate it more adaptively, transforming it from a raw, present tense threat into a processed, past tense event, like filing it away properly. So both PE and EMDR, through different means, are working to undo that fear conditioning and break the hold of avoidance.
Okay, we've covered a ton of ground. Let's pull together some key distinctions mentioned in the notes to make sure the clinical picture is crystal clear for you, the listener.
Good idea. The first two are crucial time and focus distinctions. We've hit this, but it bears repeating. PTSD versus post-trauma syndrome. That's the difference between symptoms lasting $1 a month versus resolving in $1 a month. Big difference in prognosis and approach.
Right. 1 month is the line.
Second, distinguishing PTSD versus grief. While they often overlap, PTSD's core is the threat response fear, intrusions, avoidance related to perceived danger. Grief's core is the response to loss. You treat the fear differently than you treat the sadness or guilt of loss, although, as we said, you often need to address both.
Got it. Threat versus loss. And the third critical point the notes hammer home is the avoidance trap. Let's just underline this one more time. Why does avoidance feel helpful but is actually so damaging?
Because it provides immediate relief. It works instantly to reduce anxiety in the short term. That relief is powerfully reinforcing. But, and this is the trap, every time the person avoids, they miss the opportunity to learn that the feared situation might be safe now. The fear never gets challenged, never extinguishes. Avoidance maintains the PTSD.
So clinicians need to help clients see that short-term relief comes at the cost of long-term suffering.
Precisely. Reframing avoidance not as successful coping, but as the mechanism keeping them stuck is essential.
Okay, to make all this theory concrete, let's quickly walk through the mini case study provided. We have a 32-year-old, 3 months after workplace assault. Symptoms are avoiding elevators, startling easily at footsteps in the hall, having fragmented memories of the assault, and nightmares about it twice a week.
All right, first check. Duration is 3 months, so that's well over the 1-month PTSD threshold. Now, let's map the symptoms to the 4 clusters. Nightmares. That fits re-experiencing,
Yep.
avoiding elevators, clear avoidance, fragmented memories. That points to negative alterations in cognition, specifically amnesia aspects,
Okay.
and startling at footsteps, classic arousal hypervigilance. So she meets criteria in all 4 clusters, plus the duration requirement, diagnosis, PTSD.
And the intervention plan laid out follows directly from everything we've discussed.
It does. The plan would typically involve immediate psychoeducation about PTSD, establishing trauma-informed care principles, teaching grounding techniques for managing the startle response and any potential flashbacks, likely initiating a first-line SSRI like sertraline to help manage symptom severity, and critically, a referral for trauma-focused psychotherapy, CBT, PE, or EMDR would all be strong considerations here.
Right, targeting the avoidance, the memories, the beliefs.
Exactly. And then ongoing monitoring of functional recovery. Is she eventually able to use elevators again? Can she feel safer at work?
That really illustrates how the models and interventions connect. Okay, let's wrap up with the vital warnings from the notes. The common pitfalls that anyone working in this area needs to watch out for.
These are really important takeaways. First, don't mistake avoidance relief for actual recovery. Just because someone's anxiety is lower because they've restricted their life doesn't mean they're better. Real recovery involves expanding life, not shrinking it.
Good point. What's next?
Second, never miss pediatric regression. Always be looking for those behavioral flags in children. The bedwetting, the mutism, the specific quality of trauma play. Don't just rely on them telling you what's wrong.
Crucial for kids. Third pitfall.
This connects back to TIC. Don't rush trauma narratives. Creating safety, teaching grounding, and ensuring the client feels in control and ready before diving deep into traumatic details is paramount. Rushing can easily lead to re-traumatization and shutdown. Safety first.
Absolutely. And the final warning.
Don't underaddress the environment. Remember the psychosocial model. Recovery isn't just an internal process. You have to actively assess and, where possible, bolster the person's social supports, consider cultural factors, address ongoing stressors or safety issues. If the recovery environment remains hostile or isolating, even the best therapy will face an uphill battle. Hashtag tag outro 10.
Wow. That was an incredibly detailed journey through these notes. We've really unpacked the entire clinical landscape of PTSD, haven't we? From the 4 core symptom clusters to dissecting those 4 etiological models linking brain structures like the amygdala and hippocampus directly to symptoms like hyperarousal and fragmented memories. And then detailing the full clinical toolkit. The role of SSRIs, the specifics of grounding techniques, and the mechanisms behind therapies like PE and EMDR, how they actually work to reprocess memories and break that avoidance cycle.
Yeah, we covered the critical differences too. PTSD versus the acute post-trauma syndrome based on that 1-month mark, and PTSD versus complicated grieving, focusing on threat versus loss. And we kept coming back to that crucial warning about the avoidance trap. Hopefully you, the listener, now have a really deep practical grasp of this complex condition, all drawn from these comprehensive notes.
Okay, here's where it gets really interesting. Thinking about that cognitive model.
Right. If we circle back to that idea from the cognitive theory that PTSD is fundamentally rooted in those shattered assumptions about safety, trust, meaning, the self, the world, then recovery is really this profound act of rebuilding.
Rebuilding trust in a world that proved untrustworthy.
Exactly. So the final provocative thought we want to leave you with, something to mull over, is this. If recovery means painstakingly rebuilding those core assumptions, what might be one foundational assumption, maybe about predictability or connection or one's own capacity that, if it could be slowly, carefully proven reliable again through daily experience and effort, might just start to shift the entire structure? What single belief, once rebuilt, could become the cornerstone for restoring a broader sense of safety and meaning after trauma? It suggests recovery isn't just about processing the past, it's about actively constructing a new, viable future, one assumption at a time.
A really powerful question about the architecture of healing and resilience. Thank you for sharing such incredibly thorough material for this deep dive today.